Mostly just going to be a technique presentation here, but for all the things, Dr. Bowers did a great job at talking about the pros and cons of the different types. When I started out, I came in with some advanced laparoscopic training, and we used to have a competition to see who could put more mesh in and what was the biggest piece of Gore-Tex you used, and I used one, and we used to think that that was great. And when I got into practice for real, patients just were miserable. They all came back with pain at the transfascial sutures, and that's what really sort of motivated me, in addition to the eventrations that Dr. Bowers points out. And they would come back and say, my hernia is back, and of course their abdominal wall was bulging. And then once a year at M&M, somebody's presenting a missed enterotomy from the laparoscopy and lysis of adhesions and things. And I really got a little disaffected with the laparoscopic approach. And I thought I invented this operation. One day I was doing a stomach hernia repair, and I got down, got the sac taken apart, and all of a sudden I was in the retrorectus space, and I put the posterior rectus together and thought, God, that's a great place to put mesh. It's not next to the bowel. And I went running to my boss, and I said, Phil, I got a new hernia repair. I just found this new space, and we can do it. He said, in the 40s we were doing that, and look up Stopa, and look up, all right, fine, I'll never be famous. But anyway, so I fell into this operation, did the research, and I think there's some real advantages, and you can see the MOC asterisks here. I think, what I want to do is reconstruct the abdominal wall for the reasons Dr. Bauer mentioned. I don't like mesh in contact with the bowel. I don't like those large subcutaneous dissections, and I would like to think that that's part of my contribution to my technique here that may save you some of those soft tissue infection complications, and avoiding those transfascial sutures and using the cheapest mesh that we have, a standard weight polypropylene mesh. In some of the discussions we had about stop smoking, this is a partnership. I tell these patients, especially the bigger, sicker patients, more difficult hernias, I tell them this is not, you come in and show us your insurance card and we fix it, no big deal. This is a partnership. They have to do their part in getting ready for surgery. That's stop smoking. I do test them. I have sent people home when they come in smelling like an ashtray from the pre-op room. I have the luxury of doing that, and I have support to do that. I also tell them to lose weight, and the heavier the patients are, as a bariatric surgeon, I have no qualms in telling them they need to have bariatric surgery if they meet qualifications, and getting them through so that we can do this successfully and reconstruct their abdominal wall. This is the ideal patient. I'm going to show you a video in just a second. This is a different patient.